Jim, I can't believe this is your 50th episode. This is so exciting.
I know, I'm really excited too. I can't believe it.
Well, I think in honor of your 50th episode, it would be especially fun if you're the one who gets interviewed instead of you interviewing me. How's that sound?
Sounds good. Let's do it.
This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the Brainwaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com.
So what are we going to talk about today?
Well, no, I figure since you've spent all this time interviewing people about their favorite topics, that it makes sense for someone to interview you about your absolute favorite topic in neurology, large vessel disease. So let's start off with a case. This is something that we probably see every other day on the stroke service. A 65-year-old man with coronary disease, hypertension, and diabetes presents with sudden onset of aphasia and right hemiparesis. He receives IVTPA with some pretty significant clinical improvement, is admitted to the stroke service, and his workup is notable for 69% stenosis of the left internal carotid artery. So in addition to usual acute stroke management and workup, what should we do in terms of secondary stroke prevention?
I guess as part of the acute stroke management in patients, we'd like to place their head a bit flat, liberalize their fluid resuscitation measures to make sure that they're adequately volume resuscitated and their blood pressure is elevated to a degree that's safe for reperfusion. And then kind of optimize their neurologic status by making sure that they're euglycemic, normothermic. And given that we think that this patient has a symptomatic left ICA lesion, perhaps increasing cerebral perfusion by liberalizing the blood pressure may be of some benefit for this type of patient. Long term, however, the use of statins, HMG-CoA reductase inhibitors to reduce plaque in these patients and also prevent secondary stroke, as well as the use of antiplatelet agents, specifically aspirin in this case, is going to be of benefit for this type of patient.
There have also been a number of studies that have evaluated the surgical options for this type of lesion. And like coronary artery disease, we know that angioplasty alone is marginally effective in carotid atherosclerosis. According to the Carotid and Vertebral Artery Transluminal Angioplasty Study, CAVITAS, and the stent-protected angioplasty versus carotid endarterectomy trial, the SPACE trial, balloon angioplasty was associated with a 30% risk of 2-year recurrent severe stenosis during follow-up, whereas stenting was associated with only a 10% risk of recurrent stenosis, and endarterectomy in these cases carried a 5% risk of recurrent plaque buildup. So we know that angioplasty alone is ineffective, but angioplasty plus stenting reduced the risk of recurrence significantly. Fortunately, other clinical trials, notably the AVA 3S, CREST, and International Carotid Stenting Study, showed no significant long-term difference in the risk of recurrent stenosis between patients who had stents placed or who had endarterectomies. So they're considered equivalent interventions as far as long-term risks of recurrence are concerned.
Before we send this patient off to the OR, maybe we should talk a little bit about the different ways that we describe large vessel disease and atherosclerosis. So symptomatic versus asymptomatic, that seems pretty clear. But sometimes I hear people use the term like hemodynamically significant versus insignificant, whether it's high-grade stenosis or moderate or low, and people assign different percentages through a number of different measurements. So how do you qualify and quantify large vessel disease?
So that's a great question, and historically stroke was attributed to flow impairment by the narrowed vessel, but we've not thought that to be the case for some time. After decades of experience by doctors with much grayer hair than me, only a minority of patients were observed to have such severe stenosis to become symptomatic of hypoperfusion, resulting in stroke. More interestingly, patients from the NASCET and ECST trials with more than 95% stenosis, called near occlusion, these patients were found to have a lower rate of stroke using medical therapy alone and had no relative benefit from surgical intervention after 5 years. Therefore, other plaque characteristics have been studied, things like an irregular or ulcerated plaque surface, a heterogeneous plaque with echolucency that indicates necrosis, and intraplaque hemorrhage, which you can identify on ultrasonography using B-mode imaging. And these correlated with a much higher risk of infarction. For instance, the presence of intraplaque hemorrhage may progress rapidly despite statin therapy, and is associated with a 6 to 10-fold greater risk of ipsilesional stroke when compared to plaques without internal hemorrhage. So these are the kinds of plaques that we want to intervene on more urgently. As far as the degree of stenosis is concerned, mild, moderate, or severe, we usually quantify this using the NASIC criteria, which approximates the intraluminal stenotic diameter compared to the more distal intraluminal diameter of the internal carotid artery. So a 50 to 70% stenosis might be mild or moderate depending on the institutional criteria you're referencing, and a 70 to 95 or 99% stenosis might be more moderate or severe. You can also quantify the degree of stenosis according to carotid ultrasonography using velocity measurements of the arterial blood flow through the stenotic lesion. So for a mild or moderately stenotic internal carotid artery, a 50 to 69% stenosis according to CTA or MRA may correspond to a 125 or 230 centimeters per second peak systolic velocity, whereas a stenotic region of the ICA that's greater than 70% stenosis, that may correspond to a greater than 230 centimeter per second peak systolic velocity on the ultrasound. And obviously a patient with total occlusion, you wouldn't perceive any blood flow through that affected artery.
So just to clarify, does a carotid plaque have to be at least moderate or severe stenosis to cause a stroke? Or can you have a stroke from a mild plaque that just wouldn't benefit as much from revascularization?
You know, I think that's a great point. A plaque does not need to be greater than 70% stenotic at the time of the ultrasound of the CTA or MRA. For instance, you can imagine that a 70 or 80% stenotic lesion in the left ICA could ulcerate and embolize, and by the time the patient presents clinically, much of that plaque could be gone by the time you image it. So it could look like it's 35, 40, 50% stenotic and would only be mildly stenotic at that time. And based on the current data that we do have from multiple clinical trials, that patient still wouldn't necessarily benefit from endarterectomy or stenting now that the degree of the plaque burden is much lower. But that doesn't mean that the stroke mechanism was not attributable to the carotid lesion.
In a nutshell, I guess, who are the patients who we should be referring for revascularization, and then what are the different techniques that we can use?
There are two ways to kind of answer this. First is we think of any patient who comes to the clinic who may have carotid stenosis, and those are kind of your asymptomatic carotid stenosis patients. According to several trials and a pooled analysis from at least 3 of the major randomized controlled trials, patients who have an asymptomatic carotid lesion, meaning a lesion that's not produced a hemispheric event or a transient monocular event, those patients, if they have a stenosis of 60% or greater, may benefit from revascularization within the long term, meaning 5 years or more, if they meet certain criteria. And those criteria are kind of more rigidly defined in the literature. And specifically, those patients need to have a low perioperative risk of less than 3%, mortality. So if they have, coexisting severe coronary artery disease, multiple stents and interventions, and COPD, and they may be difficult to wean from a ventilator, they may not be your ideal surgical candidate for an asymptomatic lesion. Whereas patients who have symptomatic carotid stenosis, meaning an event within the last several weeks to 6 months of a, stenotic lesion of the carotid, those patients we would refer to surgery, whether it's endarterectomy or stenting, if the degree of stenosis is 50% or more.
You mentioned plaque characteristics. Is there anything else that we can do to risk stratify people with asymptomatic stenosis?
Yeah, so some centers will actually use transcranial ultrasonography, or TCDs, transcranial Dopplers, to evaluate for high-intensity transient signals in order to risk stratify these patients who have an asymptomatic carotid artery stenosis. And it turns out that the more signals that you detect by insunating the middle cerebral artery, for example, it does correlate with more heterogeneous or ulcerated plaques or more severe stenosis of the carotid, which may indicate higher risk of future embolic events.
So that's asymptomatic stenosis. Now let's move on to symptomatic stenosis. Who are the patients who are good candidates for revascularization, and how much do they benefit?
Sure. So in general, if a patient comes in with a symptomatic carotid lesion, they're at a very high risk of having a recurrent cerebrovascular event. These patients are at a 25% 5-year risk of a recurrent stroke, according to some longitudinal cohorts, and that can be significantly reduced with intervention. And this is a much larger number than we would see with the asymptomatic carotid stenosis group, where they may have 5 or 10% 5-year risk of ischemic strokes.
Jim, is that risk just distributed evenly over the 5 years, or is it weighted more towards the early peristroke or later peristroke period?
The risk is definitely an upfront risk, with greater risk earlier on after the initial cerebral ischemic event, followed by a very precipitous fall in the risk after 2 weeks, and after 90 days it almost normalizes to your general population's risk of stroke. One study of patients with large artery atherosclerosis showed that 21% of patients had recurrent neurologic symptoms or worsening due to new embolization within the first 72 hours. Between 72 hours and 7 days, that risk of recurrence dropped to 6.7%, and then again dropped to 3.7% by 14 days. So the risk of a recurrent stroke in the setting of symptomatic carotid disease seems to drop pretty precipitously after the first 2 weeks. And that seems to be one of the major driving factors in getting patients an endarterectomy or stenting within the first 2 weeks, because that risk of early recurrence is so great during that time period. This is probably also a good time to mention some of the other prognostically useful factors in determining what kind of patients would respond better to surgical intervention for carotid disease. And two major factors seem to stand out when it comes to prognosis for endarterectomy besides simply the degree of the stenosis. These are gender and the severity of symptoms. In both the ACAS and the NASCET studies, women who had symptomatic 50 to 69% stenosis failed to benefit from endarterectomy. So in addition to male gender, the older patients and those who underwent surgery within 2 weeks of stroke symptoms seemed to gain the most from carotid intervention. As far as symptom severity, amaurosis fugax is associated with an incredibly low risk of recurrent cerebral ischemia, so patients in the NASCET trial who presented with retinal TIAs were much less likely to benefit from surgery. And this probably contributes to why we don't include retinal ischemia or amaurosis among other risk stratification schema, such as the ABCD squared score. You don't see amaurosis among those criteria that suggest a patient's at a greater risk of recurrent ischemia.
What if someone has a really large stroke?
If someone has a very large stroke and when to intervene? So although I am saying that the timing of intervention is important here, especially because the risk of recurrence is the greatest within 2 weeks, it's really unclear at this point whether early or delayed intervention is better in these patients. And current guidelines don't recommend a specific timeline after symptom onset, but I've seen a lot of centers prefer earlier intervention, usually within 2 weeks or so, to anything that's delayed for patients who are neurologically stable after their stroke. And that's the important part, is if they're neurologically stable. This practice seems to stem from some lower quality data involving some smaller trials, and certainly patients who have an intraluminal thrombus associated with a ruptured plaque, those patients may benefit from more emergent intervention due to the high risk of early recurrent stroke. That being said, both CEA and carotid artery stenting both carry significant perioperative risk of recurrent infarction and other surgical complications, and those must be considered when making your decision. As far as the patient you mentioned who has a very large stroke or very large territory of infarct, those patients may be too unstable to have earlier intervention, and so a delayed endarterectomy or stent would be appropriate for those types of patients. As far as anticoagulation goes, we know from the International Stroke Trial, where patients were actually treated with heparin historically, that the risk of hemorrhagic conversion was slightly greater than the benefit of prevention of recurrent stroke when compared to aspirin, whereas aspirin does give you better risk control for recurrent cerebral ischemia, but doesn't carry that same risk of hemorrhagic conversion. So unless we're treating something like a cervical artery dissection, which is kind of beyond the scope of this talk, we typically wouldn't anticoagulate a patient for an acute large artery atherosclerotic lesion. That being said, for patients who are going to the OR for endarterectomy, it's more up to the discretion of the surgeon whether they want to anticoagulate them preoperatively or perioperatively, or load with clopidogrel in addition to aspirin in order to achieve adequate platelet inhibition.
So just to summarize what I've learned so far, because this is something I always forget immediately after I learn it, patients with symptomatic carotid stenosis benefit more from revascularization than asymptomatic patients do, and among symptomatic patients, men benefit more than women, and especially in older age. We've talked about revascularization as a general term, but there are a couple of different ways of doing this. So what are the different methods for revascularization, and how do they compare to one another?
So we've already kind of talked about the difference between endarterectomy and stenting and which patients may benefit from which types of procedures. And I kind of neglected to mention that before we used CEA and carotid artery stenting, we used to perform external carotid to internal carotid bypass surgery in patients who had symptomatic internal carotid artery stenosis that was surgically accessible. However, the risks of those procedures were too great, and that was quickly abandoned. Even so, one trial just recently evaluated whether EC to IC bypass surgery would be of any benefit for patients who have carotid occlusions. And it turns out, according to that study, the COST study, but the trial had to be terminated early due to futility because the rates of the primary outcome measure were no different between the surgical arm and the non-surgical arm. As far as whether to perform an endarterectomy over an ICA stent, that's a much more difficult question to answer. And perhaps the most important trial to date which has tried to address this question, the CREST investigators randomized over 2,500 patients to stenting or endarterectomy for symptomatic or asymptomatic stenosis, and about 47% of the patients had asymptomatic large vessel disease. The primary endpoint of any stroke, myocardial infarction, or death in the perioperative period or ipsilesional stroke within 4 years was no different between either arm of the study, the endarterectomy or the stenting arm. That being said, there was a slightly lower risk of perioperative stroke in the endarterectomy group and a slightly lower risk of myocardial infarction in the stenting group. Older patients in general fared better with the endarterectomy than with stenting, and younger patients fared better with stenting than with endarterectomy. And while we think of these results all the time when deciding which patient should go to the OR and who should go to the angio suite, we also consider the location of the plaque, meaning if it's too high up or if it's surgically inaccessible, but still extracranial, then stenting is really the only option. But if there's a dense atherosclerotic disease burden of the aortic arch and the carotid, which might risk perioperative stroke too greatly if stenting is considered because you're going up with a catheter, that patient might go for CEA instead. And we also consider the morphology of the plaque, with more heterogeneous plaques that have intraplaque hemorrhage being among those we might consider sending to the OR for endarterectomy instead. And as far as stenting goes for the internal carotid, we know that only the extracranial portion of the internal carotid should be stented, because we know from the Sampras trial that patients who have intracranial ICA lesions or other branch lesions are more likely to develop strokes or hemorrhage from ruptured arteries during the procedure if a stent is attempted, as compared to medical management. So these patients are best managed medically with dual antiplatelet therapy, things like aspirin at high dose 325 milligrams and clopidogrel 75 milligrams daily, plus atorvastatin, which is high dose.
So getting back to our original case, we said this was a patient with a recent ischemic stroke who had 69% internal carotid atherosclerosis, at the level of the carotid bifurcation. So what should we do in terms of addressing the underlying etiology of his stroke to prevent future recurrent stroke?
It's first worth noting that even though we think we found the mechanism of stroke in this 69% left ICA stenosis, our patient may have a more likely mechanism of infarct or a second mechanism of infarct, depending on how his brain imaging looks and other clinical features. As many as 1 in 20 patients may have more than one mechanism to account for his stroke, and recognizing atrial fibrillation in this patient, for example, would dramatically change his management. So he still warrants a complete workup, including transthoracic echocardiography, and a minimum of 24 hours of telemetry monitoring, laboratory studies to evaluate for any other underlying risk factors for cerebrovascular disease, and so on. As far as treatment goes, he will require a long-term antiplatelet agent, either with aspirin or another agent as long as he can tolerate it, as well as a lipid-lowering therapy. I like rosuvastatin and atorvastatin. To treat his underlying disease mechanism, which we think is the 69% left ICA stenosis, I would recommend carotid stent or endarterectomy because he's a male, he has a recent symptomatic event, and it's within the distribution of the internal carotid artery, which is stenotic to greater than 50%, suggesting that he would be the kind of patient who benefits in the long run from intervention. In choosing which procedure he may benefit more from, it's tough to say, but I would prefer him to undergo endarterectomy because he's a little bit older, he has no medical problems to indicate to me that he would be unable to tolerate the surgery, and the lesion is surgically accessible since you said it lies at the junction of the external and the internal carotid. The fact that his left ICA is the one that's stenotic throws a bit of a curveball into this case. Pooled analyses from several major clinical trials indicate there's about a 36% greater risk of perioperative stroke or death following endarterectomies of the left ICA as opposed to the right ICA. So even though he's at a slightly greater risk of perioperative stroke or death, it's still a very low risk, about 3% versus 5%, but it's a risk to be aware of.
Well, Jim, I hope you enjoyed your turn giving the interview rather than conducting it. I know I really learned a ton.
I'm sorry to let you down.
I'm going to ask you which trials you rely most heavily on. We'll do this another podcast later.
You really wanted us to do... You wanted me to talk about the Capri
I really did.
Thanks for listening to Brainwaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com.
Be sure to check out our iTunes archive for older episodes.
This episode was produced by Jim Siegler.
Music by Josh Woodward.
I'm Erica Mejia. Join us next time for another edition of Brainwaves.